So we'll do the physiology of the male, okay? Spermatogenesis. Basically, what that is, in a nutshell, is making sperm, okay? The process in forming a mature spermatocyte. Now, we'll talk a little bit later about meiosis and how to make what we call a haploid, half the number of chromosomes. But before we do that, we would have to become what we call spermatogonia. And what they are is these immature cells in the seminiferous tubules. And keep in mind, the seminiferous tubules are located in the testes, or testicles, okay? And these just go through mitosis, not meiosis. A lot of these cells will, well, they're basically doing this. When we get into meiosis, it'll make more sense. One cell will have 46 chromosomes. So here's the spermatogonia cell. There's 46 chromosomes. Let me make it a little bigger. 46 chromosomes in here. It's going to go through mitosis, make the same number, 46, 46. We'll split up again, make 46, 46, 46, 46. It'll keep on doing that, so forth, right? And so forth, 46. That's mitosis. You get one parent cell that makes two identical daughter cells. Same number of chromosomes and all that. That's mitosis. Now, one of these cells, instead of going down this pathway, can decide to go through a series of other divisions, which we'll go into another time. And what will happen is this will split up to become 23, and you'll end up getting 23 chromosomes in each. These can have a tail, and that's what your sperm is. But we can make more of these, and each one of these has potential to become a sperm. Now in males, we keep on making this spermatogonia until the ripe old age of death. It slows down a little bit as we get older, but we're always making more and more of these spergonia. So therefore, we'll always be making more and more sperm. That's where you hear the stories of an 80-year-old person getting someone pregnant, right? I just found out that, this is just coincidental, I just heard on the news, that Mick Jagger from the Rolling Stones, I don't know how old he is now, but it was like probably in his 70s. Yeah, 70s. He just became a new father. All right? Now listen to this one. This is off topic a little bit. He just became a new father. He has, you know how many other children he has? 7. So I think this is the 8th one. Do you know what the ranges of his children are? 17 and 45.
Well, now it's like 0 and 45.
Right, but 17 and 45, I think he's got 5 grandchildren and 1 great-grandchild. And this great-grandchild is now 2.5 years older than his new son, or daughter, whoever it is. It makes you wonder. But how does that happen? Because men can still get women pregnant, because we're producing all these. Women can't. When they're born with those 4 million eggs, that's it. They can't make any more. But a man can keep on doing this. Does that make sense? So we're basically making more spermatogonia in the factory. But women can't. It stops. Okay? Does that make sense about that? Okay? So some of them will divide and become more spermatocytes, spermatogonia. Some of them will go into a different process and actually make spermatocytes. These are diploid because there's a full set of 46 chromosomes. These are considered haploid because they only have 23 or half the number of chromosomes. Okay? This is all mitosis, but one of these cells can come out of here and do mitosis. Okay? Now, that's pre-puberty. Okay? But at puberty, what will happen is FSH and LH are going to. Now, we've been talking about FSH and LH in terms of female, but there's also things going with the male too. Okay? FSH in males are going to make the seminiferous tubules enlarge. It's very analogous to what FSH does to a female. They make the follicles enlarge. The follicles will hold the egg. The seminiferous tubules will be holding the sperm. So it's analogous here. Okay? So they make the seminiferous tubules enlarge, which means the testicles will enlarge. And for a doctor to examine a boy to see if they went through puberty, you can see the testicles are enlarged. This causes the primary spermatocytes to divide to become secondary spermatocytes. This thing. Okay? And then afterwards, the secondary spermatocytes divide to become spermatotids. So what we're saying over here is that this is a primary spermatocyte. They divide to become secondary spermatocytes, and then these actually become spermatotids. And once they develop, they have the tails. Now they're actually spermatocytes. This is meiosis 1, the first cell division. This is meiosis 2, the second cell division. Right? You learn about meiosis and genetics in the other courses. You're going to have to bring that back into this course. LH. LH in males, LH in females is that it's going to trigger ovulation. This is, in males, LH is going to cause the testes to secrete testosterone. Okay? And this, at puberty, is going to, the testosterone is then going to give the male sex characteristics like the deepening of the voice, the hair growth, and so forth. This is what happens at puberty. The testosterone are also going to mature the spermatocytes, give them the tails and stuff, so they can swim. All right? So you can do this on your own. It's what I basically drew for you over here with a primary spermatocytes, secondary spermatocytes, and so forth. You can see what it all happens. And these are the male sexual characteristics that I'm sure you're well aware of. We all dealt with our lives as a 13, 14, 15-year-old boy, or at least you had classmates with this, or brothers. Okay? Meiosis. One sex cell divides into 4. One will divide into 4. You get 4 functioning spermatocytes here. That's a key thing. 4 functioning spermatocytes. They will all work that way. That's different when we deal with females. The spermatozoa, the head is going to have, that's where the nucleus is, and that's what's going to have the 23 chromosomes. The tail itself is just to get from one place to another, to get to the egg. The acrosome is a covering around the head, and it contains 3 enzymes. It's going to finally get to the egg, and there's a barrier around the egg that's called the zona pellucida. Sperm can't get through there. However, the sperm opens up its head, allowing those 3 enzymes to come out, and starts gnawing away at the zona pellucida, the shell around the egg, so that this sperm can actually get inside. Okay? So a gamete is a sperm. A gamete is the actual functioning sperm, as much as it is the actual functioning egg. It contains half the number of chromosomes, 23. When you have 23 from the egg and 23 from the sperm, they unite and you got your full-fledged, full set of diploid chromosomes. Okay? And that's what a little guy looks like, right? Again, just going through the steps is a little bit more clear. Plus you can see the acrosome here that contains the enzymes at the tip of the head. Again, this is a close-up of the two. And this is also a cross-section of the seminiferous tubules, kind of showing you where this all lies. Remember, seminiferous tubules are located in the testes, all coiled up in the testes, and that's the factories that are going to make the sperm. Sexual arousal. The erection is controlled by the parasympathetics. And that's when the erectile tissue fills up with blood. And then when it gets engorged, it creates the erection to penetrate the vagina, to allow the sperm to enter. Ejaculation is controlled by the sympathetic nervous system, right? You learn about parasympathetic and sympathetic. Here's a little mnemonic. I don't think it's too risque to talk about here. Parasympathetic, P, right? Parasympathetic is for pointing. Sympathetic is for shooting, right? SSPP. Does that help you? Okay? You do need to know that. If someone has a problem with erections, now, what is the most common reason why there's a problem with an erection? Or an ejaculation, for that matter? The most common reason is psychological. There's too much on the mind, there's too much stress. That's the most common reason. There's other reasons that are more organic, and you got to rule those out too, otherwise we'll just say it's psychological. But one of the ones that most people don't think about is diabetes. Diabetes, because it affects the microcirculation, and it affects the small neurons that are going towards the penis, that it's difficult for that person to create an erection because it's not as sensitive. It's more like numb. Okay, so diabetes is one of those, I wouldn't say hidden causes, but it's an underlooked cause that people are not thinking about, and it should be, if you have a patient who's a diabetic, you should ask the patient, how's your sexual life? It's an embarrassing thing, but in my field, it's something we always ask, because that's something that patients don't like to talk about, and they think it has, but I'm 7 years old, why should I? Yeah, you should have a good sexual life, until the doctor says you can't, right? You have too many heart attacks, kind of thing. But it's an important thing. If someone's a diabetic at 45 years old, you should ask them about that, because they might be too shy about it, and that can cause divorces and things, right? I don't want to get too much into that, but it can cause those problems. But it should be asked about. So ejaculation is when the muscles in the perineum contract, and that's when the spermatozoa move from the vas deferens, which has been there. The sperm have been sitting in the vas deferens for a number of months, and they go into the ejaculatory duct and get mixed with the seminal fluid that you've all listened to or know about, right? Fructose, sugar, gets added into the fluid so that the sperm are a little bit more active than usual, and that's what happens there, okay? So sperm mixed with the fluids and the rest of the glands as discussed. Semen is sperm and the fluid together, okay? Ever heard of a vasectomy? Right? A vasectomy is cutting the vas deferens so that there's no communication. There's a certain section gone, right? So if you have, if this is the testes, and here's your epididymis, and then the epididymis creates this thing, is the vas deferens. Oh, I'm not drawing correctly. I'm a gynecologist. I don't deal with this as much. But basically what's going on here is this kind of a setup. And this goes into the penis. Does that make sense what I'm drawing here? So, here's a penis. This is the vas deferens. This is the scrotum here. See how I'm drawing it? Does that make sense? A vasectomy, if this is your, and I'll do it in red. If this is the vas deferens that goes up and over the urinary bladder and down into here, a vasectomy is cutting this, tying it here and here. So now the sperm that are made in the epididymis, or the testes and a little bit in the epididymis, they can't go anywhere. Vasectomy is cutting the vas deferens. That's what's happening. All right? Questions about that? All right? Now, important numbers you need to know. The ejaculate is about a teaspoon, 2 to 5 milliliters of semen. In that 1 teaspoon of semen, there's 300 million sperm that are active. 300 million sperm. Only 100 ever make it to the egg. Not 100 million, not 1,000. Only 100 ever make it to the egg. A lot of them die down in the vagina. A lot of them go, half of them are going to go into the wrong tube that doesn't have the egg. All right? We lose a lot. We got to produce a lot. Of the 100 that ever make it to the egg, only 1 is allowed to go inside. Okay? So there's going to be some kind of mechanism to not allow any other sperm to get in there, because if the egg has 23 chromosomes and the sperm has 23 chromosomes, that's what you want, is 46. You don't want another sperm in there, because then you're going to have 3 sets of haploids. Something we call trisomy. Okay? And most miscarriages are due to trisomy. Not because of that, but other reasons, which we'll get into when we talk about meiosis. Okay? Infertility, and I won't ask you about this, but infertility is an FYI. If there's less than 20 million sperm, we consider that infertile. That male is infertile. Okay? How long do the egg and sperm survive? Key numbers that you should know. Hint, hint. Okay? Kind of stuff I like to teach high school students too. Once the egg ovulates, it can survive in the female reproductive system for 24 hours. Now remember, day 14 is when it's usually happens. But like I said, it's not exactly day 14. It could be plus or minus 3 days. You can still ovulate on day 12 is what I'm saying. You can still ovulate on day 17. Ideally, it's usually 14 for plus or minus 3 days. And even with that, it could survive for another day. So even if you ovulate on day 17, the egg is still there on day 18. Does that make sense? This is why we're getting a lot of unplanned pregnancies. Not just this, but let's talk about the male. Once the sperm goes into the female reproductive tract, the sperm could survive up to 6 days. So now do the math. Oh, honey, you're not going to get pregnant. This is day 9 of your menstrual cycle. And you're not going to ovulate on day 14. How do you know it's going to be day 14? How do you know it's not going to be day 12? And even at day 14, you have intercourse on day 9, and you know it could last up to 6 days. You see? Put the numbers together. Okay? Like I said, this is what I would like to teach high school kids. Try to bring down the teen pregnancies. The last number I got was that I think it was like 68 or 70% of pregnancies are not planned. It's a lot. And of the 30% remaining, most of those is because they're going to an infertility clinic and they're trying to get pregnant. So they're trying to plan a pregnancy. But there's a lot of unplanned pregnancies out there.
So there's no like in between, really.
What's that?
There's no like in between, really.
That's why birth control is, it's the way to do it. All right? There is in between, but especially if a woman is irregular with her periods, which I don't want to go into, but you don't know when the ovulation can occur. And even if you have a period, where I could get into much more details of this kind of stuff on another time, which I won't, but even if you have a period, that doesn't mean you're ovulating. And even if you don't have a period, it doesn't mean that you're ovulating or not. There's a lot of conditions out there. So it's difficult. That's why using condoms and these things, well, condoms is good for sexually transmitted diseases too. It's really the only thing that's going to protect that, besides abstinence, right? So, so just birth control is the way to do these things. There's a lot of different forms out there of birth control. Okay? Questions on this? All right, so you should know those numbers. Now some clinical applications, really just about the prostate, okay? Just a fast review about this stuff. We did histology back in A&P1. Atrophy means a decrease in cell size and cell number, both. Then you have hypertrophy. Hypertrophy is just increasing cell size. And then we got hyperplasia, and this is increasing in cell number only. Does that make sense? This is the easy part. But then we have other things that are called metaplasia. Metaplasia is that cells change shape, but we could recognize it, but it's in the wrong place. They change shape because of a chronic irritation. A good example I can give you is that what's the type of tissue that should be the type of epithelium that should be lining your trachea? Oh, you guys are gonna go for a doozy when you do this final exam. What's the epithelial lining of the trachea? Pseudostratified. Okay? Ciliated, pseudostratified. Okay? Now, that's what happens. Now, a smoker is going to bring a lot more carbon smoke coming down in there and irritating that pseudostratified epithelium. Pseudostratified epithelium, is that single or is it a lot of layers? Single. All right? It just looks like a lot of layers, but it's not. So that one layer, if it gets bombarded with smoke, is going to get destroyed. So this is what your body does. It adapts to that chronic irritation of the smoke that you're inhaling. And it makes the pseudostratified epithelium become stratified. So what happens here is the pseudostratified epithelium becomes stratified epithelium, stratified squamous epithelium. So it's a lot of layers. What's the function of stratified squamous epithelium? One word. Protection. So that's what's happening. You don't want to have one layer and then smoke's going to go right underneath that one layer and destroy your underlying tissues. You want to have a lot of layers there, so it has to go through all those layers to get to. So this is what happens. This is what metaplasia is. When an area gets a lot of irritation, let's say smoke in the trachea, now the body adapts to that for the next couple of months and says, oh, we got to get an area where it's going to be nice and nice and thick. So metaplasia is where it's an adaptive kind of thing, where the tissue turns into something that's going to be more protective. In most cases, it'll be stratified squamous epithelium for protection. So we could recognize this. It's in the wrong place, though. It shouldn't be there in the trachea. You see what I'm saying?
Is it temporary?
It's temporary until the smoke goes away, and then the body has to change that, next few months or so. It's temporary. It's a protective measure. It's a wonderful thing. But that's something that's what metaplasia does. It tells us that there's some kind of irritation. Now, the irritation can cause cancer, or it might not. So metaplasia doesn't cause cancer. It's whatever's irritating it. But we could say there's something going on in that area. So that's metaplasia. What we do also have is dysplasia. We talked about that briefly with cervical dysplasia. This, for some reason, the cells in this area become cells that we can't even recognize. They turn into stars. Why? We're not too sure. It could be due to an infection. It could be due to cancer. But there's something going on over here, and we got to remove it. Does that make sense? We got to remove this type of cells. This, if it breaks the basement membrane, it becomes cancer then. So this is what's going on. Here's normal cells, and that white line over here, that's the basement membrane. If they get small in number and size, then we call it atrophy. If they become larger in size only, it's called hypertrophy. If we just increase the number of it, we call it hyperplasia. Okay? When people do muscle, like Arnold Schwarzenegger's lifting up weights and stuff, he's not making more cells. Muscles dividing, mitosis, that doesn't happen. What they do is that the cells get bigger. Muscle hypertrophy. Okay? Here's metaplasia. This is what the cells should look like, but they turn into some other cells that we could recognize they're just not in the right place. That's telling us that there's some sort of irritation, chronic irritation that's happening there. Here's dysplasia. The cells turn into cells that we can't even recognize. That's dysplasia. And if those cells break the basement membrane, cancer. Okay? We want to get rid of these. We see a lot more of this when we do pap smears. That means we see less of this because we pick it up early. That's why you should get pap smears. To avoid this from happening, you get rid of this. This is not cancer. This can lead to cancer. And we want to get rid of that before it turns into cancer. Okay? So this is where it comes to. Prostate. This is something us guys, look forward to. The prostate gets enlarged. Okay? And when it does, we call it benign prostatic hyperplasia. This is not prostatic cancer. It doesn't turn into prostatic cancer. It's just things enlarge. They get more cells there that are divided. So it's a gradual enlargement of the prostate, and it's appropriate in our normal growing, the aging process. But does it cause problems? Yeah, it can, depending on how big it is and where it's growing. So the best way you can see this is I think I showed you this before, but here's the urinary bladder. Here's the urethra. Here's the prostate. And then you have the levator ani muscle over here. And then finally, the penis. All right? You understand what I'm drawing? Okay? When this enlarges, it enlarges. The problem is is that as this enlarges, it's also enlarging this way too. And that's going to narrow this urethra. It's going to press against that to create something like this. And that person's going to have problems urinating. Even though the prostate, even though you're having urinary symptoms due to the prostate is a part of which system? The urinary system or reproductive? Reproductive. But it's causing urinary symptoms because of where it's going through. And this is what happens. This will fill up with urine. The man has to go to the bathroom 3 o'clock in the morning and only dribbling comes out because there's so much pressure over here. And then he goes back to bed, and when this gets full again, dribbling comes out. He can't empty his bladder all the way because of this narrowing here. Does that make sense? That's what we're concerned about. Prostatic cancer, you get the same symptoms, but this is the #1 cancer found in men, the #2 cancer deaths in men. What's the #1 death of cancer in men? It's the same thing as females. Lung. Okay? Lung cancer is the #1 cancer deaths in men and women. It's a slow-growing cancer, this prostatic cancer. And what they do to see if it's enlarging, because we won't know if it's enlarging because of just a normal thing like hyperplasia or it's because of cancer. But they'll do a digital rectal exam. And when they do this is where you have to know the anatomy. That the rectum's over here, the prostate is anterior to the rectum. You can actually feel it. It should be about the size of a walnut, but not the consistency of a walnut. It should not be hard. That's usually cancer, when it's hard like a rock. I usually use my nose, my lip, and my chin as 3 consistencies. It has the consistency of your nose. You don't want it soft like your lip, and you definitely don't want it hard as like your chin. Does that make sense? That's what I use when I explain things to even medical students in terms of consistencies. Okay? But you need to know this, or for you to understand this, you need to know anatomy. Where is it located? Now, keep in mind, when we feel the prostate, we're only feeling like a certain percentage. We can't feel the anterior portion of the prostate. It's impossible to get there. So we're only feeling a certain part. So we're only guessing that it feels appropriate at this area here. But we don't know what's happening on the anterior. So we have to do also a blood test, all right, that they'll do.